speaker, Sarah from Stepped Care Solutions, who is joining us this afternoon to talk through some transformation in Wales. Sarah, are you able to join us? Are you there?
Yes. Hi, good
There we
morning.
go.
Good afternoon. Took a second for me to get the permission to turn on my camera. I'd also ask you to find my colleague Alexia Jowich, who is also here, and she's going to be presenting with me. So Alexia can turn on her camera.
Perfect. We will do that behind the scenes and
Great.
make sure Alexia can turn her camera on and come off mute as well. Thank you. Do you want me, are you happy for me to just move the slides on?
You know what? I think I have ability to do that. So I will just click away if that's okay with you. I'll get us started while Alexia turns on her camera. And Alexia, I can't actually see you on my screen view, so just say hello when you get in. But again, I'm Sarah Hart. I am a clinical social worker and here with Step Care Solutions, which is a Canadian nonprofit organization. And we're here to talk about our really exciting project in partnership with NHS Wales. So about Step Care Solutions, and just checking, do I have Alexia here yet?
I think we're just struggling a little bit with
to find Alexia. Okay. No problem. I can keep going so we don't spend too much time. So again, Step Care Solutions is based in Canada, and our mission in our work is to support the transformation of mental health and substance use health systems. And our focus is on better access and outcomes, which is something I know this group is really passionate about. Our work really focuses on reframing, rethinking, and redesigning mental health and substance use systems. And we bring together a team of global experts across disciplines in an ability to work together with all of our partners. Our vision is well-being everywhere, which is a big vision, but we believe it's possible. So how do we get there? On this slide, we have a few different activities that we engage in and really think are key components to any kind of system redesign. So we do have system design and strategic planning expertise. We approach everything from an implementation science and change management perspective. We, of course, run alongside folks who are in the process of changing their system and do that in partnership and co-design through community engagement and most importantly engaging with people who utilize support services, people with lived and living experience. What we know to be true is that digital innovation is a really key component of any kind of system transformation. Here we are in 2025, and that's a really difficult thing for our field to continue to advance in. So we're thinking about ways to make care as accessible as possible through digital access as well. And then, of course, evaluation and data-informed decision-making are part of everything we do. And it really informs both the care seeker's experience and the people who work within the system.
Hi, Sarah. I'm here now.
Oh, great. Welcome, Alexia.
I won't interrupt.
So I'll just keep going. Yeah, and then I'll pass to you in just a few minutes. And Alexia is our Vice President of Implementation and System Transformation. So it's great to have you here, Alexia. So here's where we come into our work in Wales. So this picture does look a little dire. But we all know that what's happened in the past few years is that there's been an increased demand in services, and that exceeds what's available in the system, which results, of course, in wait lists and people needing to sometimes wait to be in crisis before they actually have access to care. We also know that the data showed in Wales that there was a big inconsistency between health boards and the experiences and the services across health boards. Workforce issues, as we've already discussed, recruitment, retention, development of the workforce is a challenge. And then in particular too, in Wales is some limited funding opportunities. And what that really does is it gets in the way of improving things like the estates and also digital offerings. So it's really hard to be innovative when you're squeezing every tiny budget opportunity that you have just to meet the current needs of the system. And so that makes it really hard to think about ways to work differently. But I want to make sure that we highlight that, of course, Wales is not alone. These problems that Wales has been facing are exactly what we see across the globe in our work in Canada, North America, South America. People that we work with often say their biggest concerns are wait lists, and sometimes there's access without a wait list to certain services, but for other services, the wait lists can be months or years long. The barriers to care, lots of assessments, lots of referrals, lots of things that the system kind of built in place or put in place to kind of slow up the movement through the system. But that frustrates, of course, the user and the people who work in the system. So as you can see, these things are across the board. On the other side of the slide, what we think about is what we'll talk a little bit more about today, which is our Step Care 2.0 model, which really addresses each one of these concerns. We prioritize quick and easy access to a variety of different resources and services. One of my favorite pieces is that we have a care first approach that really thinks about caring first and any bureaucracy later, and trying to reduce all of those barriers to care and prioritizing the person's strengths and capacities. Our framework has a way to organize services that promotes collaboration and easier navigation. Data is collected across the spectrum of the continuum of care, leading to more informed choices from both the care seeker and the person providing services. We found that tracking individuals tracking their own well-being really helps them increase their own mental health literacy, which is a type of data-informed decision-making. And then what we also think about when we think about workforce is that there's actually an opportunity to expand and diversify the workforce with a community-wide approach and really looking around and saying, what are the healing resources in this environment, and how can we make sure that those are included in the tent? So in this year, really exciting, spring 2025, the Welsh Government published the Mental Health and Wellbeing Strategy for the next 10 years. And what this strategy focuses on in vision in statement 4 is that there are seamless mental health services that are person-centered, needs-led, and guided to the right support the first time without delay. It's a bold statement and something we're really, really excited to be supporting. And I believe it's possible in Wales, and I believe it's possible in a lot of other systems. So I'll pass over to Alexia now that she's here to tell you a little bit more about what our Step Care 2.0 framework is.
Hi, everyone. Nice to be here, and thanks for kicking things off, Sarah. Always have to depend on our technology and also be very flexible, which is what we enjoy doing. So we'll tell you, Sarah started telling you a little bit about the Step Care 2.0 model by talking about some of how we address some of the challenges that we consistently see in many systems and services. We're started off a lot of our work in Canada and now internationally, but really the Step Care 2.0 was developed to create a continuum of care approach for a whole population, really thinking of how do we provide quick, easy access to a range of services so that we can provide support to a whole population when and when they need it. And Sarah, a little later, will talk to you a little bit about the 9 steps that we've developed over time. And so that will be there's a piece of conversation we'll have a little bit later. It's a principle-based approach with really one of the key principles you see under there in our title here is flexible and open access care. So given it's a principle-based approach, and we don't have all the principles here, but the idea is that the implementation and of Step Care 2.0 looks quite different in all jurisdictions, communities, organizations, but the principles are what's really important. And here the principal being very responsive and adaptive in both the services and the system so that we can meet diverse needs. So when people access services, there are different places in their lives. How can they, when they reach out, they're ready for something, how can we provide them a service that meets their best needs at that point in time? It's a model that recognizes that individuals can take ownership of their own mental health. It's really that recovery and resiliency approach where we recognize that every journey is different, and that we also, Sarah talked about this, that we need to keep thinking about how to incorporate technology to increase that access to a wider range of people. We know technology can sometimes be a barrier for some, but also an enabler for others, and we certainly saw that happen during the pandemic. So how do we keep building in the technology into our system as part of the offerings? And we'll share a little bit with you towards the end of the presentation today, some of the outcomes and benefits we're seeing at multiple levels. So given that we're really looking at system change, which involves lots of services within that system, really trying to look at the data around outcomes, both at the service user, of course, service providers, at those agency levels in terms of access, are we improving access, and at the system level, is it easier to access a wide range of services? You can go to the next slide, Sarah. And so we know step care is not necessarily a new approach. It's existed for at least a couple of decades, more than that, in the UK and Australia and lots of places in North America as well. There's lots of different kinds of step care. These are, bucketed in three buckets, which feels a little bit linear, but really there's a whole different range of ways step care can happen. We often see stratified models where this approach where people get an assessment, you take a look at their symptoms or functioning, and then depending on that symptom and functioning after an assessment, a certain level of care is recommended by the provider. Often that means that with higher level of needs and lower functioning means a higher level of care. Progressive models, often people start at the lower level. Everyone starts at a lower level of care unless it's substantially counterindicated, and move up the steps as needed. When this model was developed about 10, 15 years ago or so, the idea was like, how do we create that? We really focus on access. And so how do we think through creating access to all the services, because we know that people's needs will vary at different times. And even though maybe they have high needs, low functioning, they may not be ready or want a higher level of service. So really the decision making about what service to start with is based on the person's choice, readiness, and their preferred level of autonomy of how they want to interact with services at that point in time in their life. You can go to the next one, Sarah. Thank you. Some of what we've done over time, as we said earlier, that's really a principle-based approach. So we have 10 principles. We know that principles are really inspiring. They provide us direction, a guidepost, a North Star, but in and of themselves, saying, people have access to care when they're ready is a wonderful principle. How does it get operationalized? So when we started implementing this model in lots of different places in Canada and in the US, the question was, what does it look like in practice to operationalize providing access to care, for example? So we developed core components with standards and recommendations underneath one of these. And you see some are core components that really help us think through the design at the system level, and others more in terms of what's that look like at the client level, the service level. And we highlighted 2 here that are very much aligned with this idea of data-informed care, both at the continuous improvement level, quality improvement, service system transformation is never done. So how do we collect data that is meaningful, that helps us shift the system as we go? And then at the care level, how do we use data to inform decision-making and collaborative decision-making so the person can really build their own mental health literacy, understanding of their wellness, and make shared decision around what kind of care might best meet their needs at that point in time. We'll talk a little bit more about that in a few slides as well.
Yeah, so this is another piece of our step care framework, and it looks very much like those stratified or progressive models where there's increasing intensity across the continuum, and that's true. There are a variety of intensities and a variety of services on our 9 steps, But like Alexia was saying, what's most important within our planning framework is to make sure that the decision-making autonomy and the service users' readiness and investment that they need to make in the service matches what it is that they're able and willing to do at any given time. And so we think about this as a planning tool to help any system identify where are their services across this continuum? Are there gaps? And if there are gaps, what could they potentially add to their services or their system, or bring into the tent? Because sometimes those services are outside of what people might think of a mainstream health system. So how do we make this how do we utilize this framework to identify all of the variety of services that we believe make a full continuum of care? And then most importantly, arrange the access to care in a way that really encourages the service user to choose what's best for them at any given time. That doesn't mean, of course, that there aren't expertise in the level 7, 8, and 9. Of course, there's a lot of clinical expertise and clinical guidance, which is necessary at times. But what that means is that it's really more of an investment and even less decision-making autonomy as you go up to the more specialized services. What we also believe, though, is that people can use multiple services at the same time. So we know that people really benefit from peer support in a variety of different circumstances. And that peer support can be happening across the time while also engaging in intensive psychotherapies or acute or crisis care, while also maybe doing some mood tracking or using some other apps or some other self-guided resources. And that we've identified the digital access a few times, and we'll give you an example of that in just a second. But ultimately, what we think is, yes, not everybody has access to digital care, but if there's some way that they can get the information they need about the system and even access that system online or through through apps on their phone, it can be really helpful. We don't use that planning framework as an external model because it causes people to feel like they want to climb those steps. So what we do is we partner with the organizations and jurisdictions that we work with to design their own imagery around this. So we've got a few examples. The University of Toronto, I really love their example. It makes everything even or equal. There's no value that's more than the other. But it also identifies the kind of balance between self-care and care for others. The Northwest Territories in Canada added some pieces that were really important, like traditional and land-based healing options needed to be in their circle of care based on their community values and traditions. So each community kind of designs their own imagery to communicate to people what's available for them and what they might want to use at any given time. This is the digital example I was talking about. We were the lead partner in the Wellness Together Canada national portal, and we used our 9-step planning framework to inform what here is a 5-point access. So we've translated that 9-step planning framework into something like learn, practice, connect, track, and talk. And so people could go onto this portal and choose what they needed at any minute, 24/7, 365 days a year. And people varied. Sometimes they needed a crisis support. Other times they wanted to talk to peers. Other times they wanted to do some self-monitoring. So how do we do this? This is the million-dollar question, as we say, that, when we talk to people about this model that underpins a lot of that transformation, people says, oh yeah, of course, that makes a lot of sense. I'm in. But how do we get there? Because system transformation is no easy task. So we've broken down our implementation process to 4 phases that generally align with building readiness and really making sure that at every point in the transformation, we're making sure people really are ready for these types of transformations and what do they need to do to get ready. Then we move into preparing for success. So it's really about defining and planning, and then maybe getting the resources together and the strategy and the people in place, like implementation teams and that sort of thing, to support the transformation. Then we start to implement. And what we often recommend is that people start with some demonstrator projects or one component or two components. We often talk about things that we could maybe make adjustments to as soon as possible or as easily as possible to get those early wins so that it feels like things are moving. And then adding to that as we go along. And then, of course, like Alexia said, no implementation is ever done because it's always continually improving. So the ongoing implementation and improvement is key to this. What is also really important about this is that this kind of cycle is not just a one-time cycle. It kind of happens for every different component or every different adjustment that we make in different systems. I'll pass it over to Alexia to talk about the evaluation of this.
Great, thank you, Sarah. I think as Sarah was mentioning, part of this phase 3 is collecting data. So we know that once people get started on this change, we want to see how it's going, both for quality improvement purposes and to see if we're having the beginning of the impacts that we're looking for. So really planning for that evaluation, that data collection during that planning phase is critical. And what we found over time is that there weren't a lot of system models for data collection. So as we were as we're doing more and more implementation, coming up with questions, yes, around well-being outcomes, mental health outcomes, but also awareness of services. So we developed these domains for our evaluations that are gather data both at client level, provider level, organization level, and system level. That those are really the questions that people were coming up with. How do I know that, yes, we have these services across the 9 steps, but are people aware of them? We know it's a huge gap that sometimes there are often excellent services across the continuum, but people aren't always aware of what they are and how to access them. And then measuring around access. How are we improving access? To what? What are the impacts of that? We've seen lots of data around satisfaction, wanting to know, are these changes still aligned with what clients are looking for, but also providers? So we've seen some interesting data at the provider level that this approach to access really supports providers to feel like they're meeting the needs of the clients that they first, why the reasons they decided to go into this field. Of course, well-being, so anything from, yes, mental health outcomes, depression, anxiety, but also wellness and functioning, etc. So every jurisdiction we work with chooses different measures along these, but these have been the consistent domains we've seen. And ultimately, system integration. So it's great to have services across a continuum, but again, regardless of where we work, this idea of how are the services working together? What's that integration look like? How do clients move through the system in a more fluid way is of huge importance as well. So looking at some data across all of these domains, and of course, these 4 that you see in the circle underneath cut across all of these domains. So looking at equity, is there equity of access? We see that again, that often when we look at who's accessing the services, it's not necessarily always proportional with the population that exists in that jurisdiction. Of course, return on investment, value for money is really important. People invest in this change. Is it leading to a return for the system at large? Sustainability, where we'll often really, through those phases of implementation, Sarah talked about thinking through sustainability from the outset, right? So how do we plan for changes that can be maintained over time? And then looking at the impact of implementation. What are we learning as we're making these changes? And those are some of the key questions, many of these that the team in Wales is developing right now as we speak. And so we'll share a little bit more about that with you in a few minutes as well. And go to the next one, Sarah. Sarah referenced the term data-informed decision-making. It's the term that we've been using for that monitoring across the whole system, but also a slightly different than measurement-based care. So in lots of jurisdictions, measurement-based care means collecting data on an ongoing basis for the client and the provider to make decisions around care. And absolutely, that's critical. Most times that's used primarily in ongoing individual psychotherapy and therapy. And what we're trying to do is build a system where that measurement around what the client, the benefit to the client, the impacts of the clients of the services gets accomplished across the continuum. So whether in peer support and workshops, how can we create data collection processes across that are primarily for the use of the client or the person accessing services, so they can make decisions around their wellness. And we did that. You saw, if you noticed in the Wellness Together Canada example, that track function was really primarily for people using the service, and it did help them monitor and you notice when maybe there was a change in service or engaging in their service more fully was necessary for their well-being. So I think, Sarah, you can you can skip the next slide so that we have time for the rest here.
Yeah, so we're going to speed through a couple of these and hopefully have a minute or two for just one or two questions at the end. But the process in Wales thus far, there's been over 2 years of community engagement to discuss the current system and opportunities for change. As I mentioned, there's a development of the 10-year mental health strategy and a 3-year implementation plan. There's, of course, continued and ongoing engagement and co-design for their model. And what they decided to do is utilize the StepCare 2.0 model to underpin and develop a national implementation roadmap following some of the steps that we've talked about today to help support their vision for transformation. And just right now, they're starting to implement with some demonstrator projects first, focusing on flexible and person-centric access or front door to services, which was a really key component of their system transformation. Related to just some outcomes that I'll go through quickly, these are some of the system impacts of StepCare 2.0. You can see the headlines there about wait times and access. We've said that over and over again. It's really one of our North Stars. But interestingly, we've also gotten data as we study the system change with StepCare 2.0 that it increases cultural sensitivity. People feel that they have more options that are culturally relevant to them. It increases attendance in the service that people choose. People are more satisfied. And interestingly also that there's that some systems notice a reduction in crises overall in their system. And we believe that's because people have the access when they actually need it, as opposed to needing to wait and identify themselves as crisis to kind of skip the line. And that we found that when using a one-at-a-time approach, which we didn't get into too much in this talk, there's more and more individual user or service users are able to be served in the one-at-a-time approach. These are my 2 favorite slides, so I'm not going to read them because we don't have time, but I want you to look at them when you get the slide deck. But this is what's most important, the words that people who have experienced this change say. One of the greatest benefits of the system is capacity for flexibility and responsivity. This one, it's given me a sense of pride to work in a system that allows me to help people in an efficient and effective manner. How wonderful is that? And then from some additional comments, just everybody gets priority now, not just clients in crisis, and etc. So thank you so much for including us in this this day-long event. We're really excited to be here and to listen into the benchmarking conversations. This is how you can get in touch with us. If we have a minute for questions, we'll be happy to answer them. But if you have a question, you want to get in touch, feel free to send us an email or go to our website. Thank you so much.
Thank you so much, both of you, and I'm glad we managed to sort the tech so that we could get you both online. Really, really interesting. I think we have got some colleagues on the call from Wales, so I don't know if anyone on the call has had experience of this and wants to share, but I haven't seen any questions come in so far. Does anyone have any questions if they want to put their hand up? Nothing so far, but we will share contact details and everything and the slides if that's okay with you, and pass on any comments and questions that do come in. But thank you so much for joining us, especially with the time difference and everything. Very lucky to